It is my pleasure to welcome Dr. Willem Back.
Thank you very much, Jason, for the nice introduction. It's a very great pleasure for me and an honor to be here and to say a few little words about what's going on with the Friesian breed. I must say I already gave this presentation for the Dutch Friesian horse owners, especially the members who are involved in the KFPS. So you will get a similar presentation. Then you know as much as they know, but I have new information, so you will have the more recent information. And what I would like to do is talk about, say, the more negative or a little bit the genetic defects today, and tomorrow about the positive aspects of DNA, and see what new information you can use to improve the Friesian horse to make it even better. To start off my presentation, I would like to show you a video and just look at it, and people who come from the Netherlands, they might recognize the language and might recognize where the people are talking about. what you're actually going to see here is the dwarf fall, which has been bored. And we'll stand up in a minute, and then you will see how it looks like. Okay, this is what it's all about. We have a mare, we have bred the mare, and then this comes out. This is what we would like to prevent in the future, of course. So how should we talk about this entity, this item? This is a newspaper in the Netherlands about horses a couple of years ago, and we are facing a challenge. What you see here is written in Dutch that they say 16 Friesian stallions, they are carrier of the Hydrocephalus gene, and 12 are carrier of the dwarf gene. It was just in a horse magazine, full of emotions, and people wrote that down. So we have a challenge, let's be honest. And what is the challenge? We see that in fact the international horse consumer, I call that the people who use the Friesian horse, they are worried because they report health disturbances within the Friesian horse breed. And then the question is this a superstition or is it reality? Genetic problems we have in every breed. We also have them in the human breed, so why bother? So we need some information on that, some scientific information, and I will give it to you and discuss in detail what do we do, what we know nowadays about all those kind of trouble, because it's trouble and we would like to prevent that. And nowadays we have tools to work on that and in the future indeed prevent it. Let's have a look. This is again the same photo. It was brought to us after a couple of weeks of age. So I would like to focus on 4 entities, just to keep the discussion as clear as possible. And if you have immediate questions, just ask it to me, otherwise we do it at the end. 4 problems we have, challenges. The Dwarfism, the Aortic rupture, the Megaesophagus, and the Hydrocephalus. These are 4 entities I would like to discuss with you. And you see the first here is the Dwarfism. That's how you're faced with, and I think in modern times like we have now, when there are techniques available to prevent this, we should work on that. Okay, let's have a look. What do we know about susceptibility of the Friesian horse breed? In fact, there's not much known about that. Megaesophagus wrote a paper about retentio secundinarum, and that should, after the fall, gave birth to, after Meg gave birth to the fall, then the amnion, the placenta remnant should be removed within 4 hours. And well, there are some problems in Friesian mares with that, but in fact, we can easily treat that. That condition is a problem, for example, in large breeds like the trekpaarden, the carriage horses. They suffer then from laminitis, but the Friesian horse, when you treat it adequately, it's easy treatable in a good way and can be cured. Nevertheless, it's there. We know it's there, and Megaesophagus, he reported about that. Then we looked at pregnancy rates between different breeds, and in fact, nothing much difference was found between the breeds. And well, the Meyer already in 1979 is one of our professors. He was involved in breeding in horses, and he was also involved in making the warm-blood horse. He already talked about that we should have a look at inbreeding. That's always the case. When you have a breed, then there's always a chance for inbreeding.
I have a question.
Yep.
I have read that retained placenta could be contributed to low selenium. Do you have any information on that?
To low sodium?
Selenium. Selenium in vitamin
Selenium. Yeah, we know that in cows. I mean, red sac, it's known to have much more causes, let's say it like that. And what I'm highlighting here is the genetic part of that. You should remember that all diseases we have 3 factors who are responsible for that: a genetic factor, an environmental factor, a common environmental factor, and a specific environmental factor. So for every disease, and for some diseases we have more genetics, for other diseases we have more environmental factors. So it's not the gene alone, or you have a mutation with a lethal factor, we come to that. That is mainly the gene, of course. But for example, when you look at aortic aneurysma in human beings, you have a genetic susceptibility for that. But to get the disease, to get sick from it, you have to not behave well when eating and drinking, let's say like that. So it's the same as red sac. Genetic is one, but there are also environmental influences. But we proved already that there's similarity between the mare and the foal, and that might have a reason why this disease in the Friesian horse will develop more than in other breeds. That's how you should look at it. Okay. Okay, to prove that we have a problem with numbers, I looked at the patient database of our clinic for surgery, medicine, pathology, and reproduction. And in fact, we found out that between 1995 and 2003, around 7% of the horses we got to our clinic, which were admitted, were Friesian horses. That's also the number of horses in the Netherlands. So you might guess that if you have a disease in which more than 7% of the horses who had that disease are from the Friesian horse breed, that there is something genetically involved. Yeah? So we focus on the 4 items, again, dwarfism, aortic rupture, Megaesophagus, and Hydrocephalus, just to give you a feel for what's going on there. First, the dwarfism. We have come at the farthest point, and now with the disease. You see here 2 adult dwarfs walking near our clinic. The eldest one we have now is 12 years old. People are very happy with it because it's such a nice horse. That's how life goes on, let's say it like that. We tackled this disease, and you see we talking about an international collaboration. We have Wageningen and Utrecht working together, We have Dublin involved in this disease, and also Cyprian Bouma, one of our vet specialists, mainly working on Friesian horses, was involved too. You see that to tackle those problems, you need more people, more specialists involved to get that done. And that works. Let's have a look. So, in fact, if you want to describe or want to find, in fact, a gene which is responsible for this disease, you firstly have to describe the phenotype in detail. Because if you have found a spot on the genome where the gene should lie, then you come up with a list of candidate genes. And then you have to find the most realistic one, go for that, and then you know that you have found the gene. Another opportunity, of course, is then when there's a disease also in human beings, in humans, a similar gene, then it's easy to get, but if it's more complicated, then you need the candidate gene approach. So firstly, we have to describe this disease. What is the difference? And here you see a foal on the left, 8 months, the normal foal, and on the right, a dwarf foal of the same age. And the person in the middle, you see that it has less gray hair. So. Not because of the Friesian horse, but children or something. No worries. So let's describe this foal. 5 weeks old, Jauke, dwarf colt. I'm very grateful to the owners that they gave me also the video information to share with you. And I'm again very happy and proud, and you should be proud of yourself that you are able to watch those slides and videos, because it's also an emotional stress. I know that, but we have to talk about it and then we can solve it. So what do you see? You see a too short suture, of course, a hyperextension of the fetlocks. You see that are much too weak, especially here in the hinds. There. You see the hinds are placed much too far behind. You also saw it on the video. They are also developed very weakly, and an hypermobility of the limb joints. So you think this foal cannot walk, trot or canter, but just have a look. This is on the straight, and this is with mummy. So you see the hypermobility. And what you should keep in mind is that these challenges, they can develop, of course, because of inbreeding, because when inbreeding you get also negative genes, say, to become homozygous and then become to, or get an expression, let's say like that. But the other thing could be that within the Friesian horse breed, we select them for a specific entity in a certain direction. So it could be that we are breeding very elastic horses, and when they are getting too much elastic, then you might appear in this region. We don't know yet, but that could be an hypothesis. You often see that when you select within a breed in a certain direction, that of course you get the best horses, but on the other hand, there's also a downside to it. So that might be something where we are facing with, just for you to think about already. So this is what we see at birth. On the left, a dwarf foal. On the right, an adult foal, or an adult dwarf, in fact. And in the middle, a normal foal. This is the length of the first phalanx. And you see at birth already the bones are too short. So in fact what we see, the foal is born with too short bones and relatively too long tendons. That's why we see the weak limbs. So again, we have to come to a phenotypic diagnosis, because then we know which gene is responsible for this entity. On the left, a normal foal. On the right, a fetlock image of a dwarf foal. We see that you get a distortion here of the bone to the back side because of the fetlock extension and overloading of the joint, and that's, you see the bone is deviating. So again, the flexor tendons are of normal quality, but they appear to be slightly more elastic. And this is how you see that the distal limbs are developing because of that. And you also see that the suspensory ligament is more distally, splitting more distally, so it's lower. That has to do, of course, with the difference in growth between the tendons and the bones. The bones are too short, the tendons are too long. That's why you see this discrepancy in relations between the tendons and the bones. And that's why the distal limbs are so weak, the fetlocks are so weak. Nevertheless, you should also remember already, that we know already, that the tendons of Friesian horses might be a little bit more elastic than in other breeds. And we're now trying to get research done where we compare, for example, the elasticity of Friesian horses with warmbloods and with thoroughbreds, and see if we can find a clue what we were selecting for in the history within the Friesian horse breed. For example, to get the tendons more elastic, and that's why we have more expressive gait or a more impressive front. We don't know yet, but that might be a clue. You understand what I mean? So we select the tissues to go in a certain direction to get the typical Friesian horse breed and the appearance. On the other hand, there's a downside, and that's what you see here. Might be a clue, but we're working on that. We look at the growth hormone axis. In human beings, it's often seen that there's a disturbance in that. But if you look at this slide with one of my female colleagues, but she's a very short lady, so. But if there's a problem with the growth hormone, then you would expect a proportional disturbance of the growth. What you see here in the dwarf foal is that only the limbs are too short, so it cannot be the growth hormone. It should be something else. So we checked that, and there was no disturbance on that. We also checked for the reproduction side. The foals or foals when they're becoming a mare, they're cyclic, they have normal ovulations, and the stallions, they deliver sperm and have a normal morphology and normal mobility. And indeed, I received the question that people had a mare, a dwarf mare, and they asked me, is it possible for me? Well, you can fill in what they asked me. I said, of course, no. But in one way or another, people are very emotional attached to these dwarfs, and they keep it, and well, some people keep it, let's say it like that. Now we go a little bit into pathology. I hope you're still with me and you can face this. Is it a problem for you, or?
That's good.
Yeah? Okay. This is the foal we saw at 5 weeks of age, and we compared it with a similar dwarf at 10 months of age. This is at 10 months of age here. So you've seen Jouke at 5 weeks of age, and this is a dwarf at 10 months of age. And things are changing. They started off with a normal rib cage, but at 10 months of age you see that there's a growth inwards. You see distortion here of the rib cage over there. And you see it also here on the right, and that's the transition from bone to cartilage in the rib cage. So apparently there's a growth disturbance there. When the foal is developing, you get a growth disturbance there, and then apparently because of that disturbance, growth cannot take place, and you get an inward rotation of the thorax. You can feel it here on the outside. The 10-month-old foal, you can feel the dip here. It's this dip. I'm talking about phenotype, I'm talking about getting a phenotypic diagnosis. That's my job. To give it to you so that together we can find the genetic background of this disease. So what can we conclude? That in fact, the phenotypic diagnosis is, what we see is a normally developed head, radiological normal but too short bones, so there's a growth disturbance in the bones, but also in the rib cage. That's why the tendons are too long, in fact, because the bones are too short, and because we also see the anomalies in the costochondral junction our differential diagnosis is angular ossification disturbance. Well, as you know, as you can imagine, there are a lot of genes involved in that. So we also have to find another way to find what's wrong on the genes with this disease. But I already promised you that I would tell you by using numbers if this is a genetic disease or not. And again, we looked at the cases of the surgery department, and we found out that it's logical, in 100% of the dwarfs we were admitted to our clinic, it was of the Friesian breed. So this is a disease where we are almost sure that it has a genetic background. No environment is involved in that, but mostly it's a genetic background. And when looking at the stallions and the mares, we think it's the one gene responsible for it, a recessive gene. So you need two of them to become a phenotypic dwarf, let's say like that. So the mare and the stallion, in fact, both, they should have the gene on board that should be heterozygous, and then you get the 25% chance of developing a dwarf foal. Okay. Any questions on this entity? Let me come to the next disease.
Is there any indication if the stallion or the mare is heterozygous? Are they slightly shorter? Do they have any, indication at all that they're a carrier, or there's no indication at all?
The question is it possible from a phenotypic perspective to see if it's heterozygous or not? To date, we don't know. No, we don't think so. The owners didn't report it to us. We don't know yet. No, I don't think so either. Nevertheless, it should be a great opportunity for us to, when we have found the genetic location, to check the mare and the stallion and see if there's a genetic background or an entity which is making the combination much more susceptible for delivering a dwarf foal. But on the phenotype, no, to date, no. Hey. Yes.
How close are you getting a genetic marker?
We come to that. No worries. First, I will describe the phenotype. The second disease, aortic rupture. What's going on there? And again, you see a lot of specialists working together with us to get that done. Lediglich Wolverga, well, you know, probably the veterinarians over there, they work together with us. Well, every veterinarian in Holland works with us, no problem. We work with them. And Utrecht and Ghent University, they're both involved in finding a clue what is the background of this disease. Let's have a look. What's going wrong? In fact, what we see is we have the aorta outside here that goes into the normal circulation, delivering blood with oxygen to the tissues, and we have here the pulmonary aorta or pulmonary artery going to the lungs to make sure that oxygen is delivered to the blood. And normally there's a connection between those two, the ductus brutali, and we see that will disappear after birth. That's the normal development. The problem, talking about the aortas, is happening here. So not here, but a little bit away from the ductus brutali over there. Let's have a look what's going on there. First, the symptoms. And I know that there are people in the audience who have seen this. What we see is a colic-like symptoms, bowing, excitation, sweating, nostril jerking. We see a high heart frequency, a bouncing pulse. You can see even, or count the pulse here on the jugular region. because there's a connection between the aorta and the pulmonary artery. You see edema under the belly and sudden death. Characteristic anamnesis or history is that you ride with the horse, you see some blood coming from the nostrils, and then suddenly the horse drops dead. In fact, there are different ways of phenotypic appearance of this disease. So in fact, what we're talking about, it's not an aneurysma like we see in human beings. So that you see widening of the aorta, and at one time then the aneurysm, the balloon will burst, and then you will have a similar phenotypic problem. It's different from that. We see several phenotypic entities. This is a very characteristic one. First of all, the free blood in the thoracic cavity, acute mortality. That's logically. I mean, that's the reason why the horse drops dead. But the other one is very characteristic, and that's what we see here. You see that there's a transverse rupture like that. This is the aorta here, and there's a transverse rupture in the aorta, just like somebody with a knife stabbed into the aorta. That's a very characteristic one. And we don't know yet how this develops. You would expect a longitudinal rupture, but it's a transverse rupture. And we now are doing histology, and we're looking around that location, what's going wrong. And even we have to go back to embryology, when tissues are coming towards each other, and forming a unity, for example with the ductus brutali, that something is going on there which goes wrong to give this phenotype. There are two other ways of showing this disease. That is in fact bleeding in the wall. So what you see here is that around the aorta there you see blood. So apparently there is a rupture in the wall of the aorta, and then blood goes outside of the aorta and stays there for a while. And we already have proof that there are horses which already have this disease for half a year or something like that. And the last one is the aortic pulmonary fistula, what we see. So we see a connection between the aorta and the pulmonary artery. And that's strange. There should be a developmental background with that. So we don't know yet. I must admit that. Are we working very hard on it? We have a PhD student now in Utrecht and in Ghent working on this, so you should be happy with that, because we really have to deal with financial cutbacks. But both in Ghent and in Utrecht, we are very motivated to find the clues for you what's going on there. Because if you find that, we know where to look for on the genome, of course. So we try to improve our diagnostic process using ultrasound, also thoracocentesis, so put a needle in the thorax, but we're also into doing pressure measurements and see if we can come to an earlier diagnosis of what's going on. And maybe we should do a performance test and see if there are horses among the population of Friesian horses, families, for example, who have a too high pulse rate when they have to do a similar performance test. There might be subclinical cases. We don't know yet, but we try to work on that, elaborate on that, and see if we can find a clue. And last but not least, we had such a subclinical, we had such a case in our clinics, and we tried to treat that with a stent to try to close the fistula, and that worked out very well. The only thing was, the stent was a human stent. It was too small, in fact, so it went away. But there are possibilities, we think, maybe in the near future, to close that. We will present that on the Voorjaarsdagen in Amsterdam, a veterinary conference, Gunther van Loon will do that from the professor from Ghent. So we're really working hard on this disease, not only on finding the genetic or the histological clue, but also possibly to find a subclinical case and even prevent them from rupturing. Yes, the question.
Sonogram here, is this at a hospital? In other words, I'm thinking about my country vet who has a sonogram, but I'm wondering if it's ability to go in and check to see if the aorta is defective with just a standard sonogram you have out in the field, or do you have to go to a hospital, equine hospital, to get a stronger machine?
Good question. The question is, how do you make this diagnosis? I think today, but I have to rely on the internal medicine colleagues. It's not easy for us to do that, but you can use your regular ultrasound machine, but you have to know where you look at. So in fact, you should go to a hospital, but I think when you go to a hospital in the US, they don't know. So we work now on how do you do that ultrasound and come up with a diagnosis. It is possible, but it's very difficult. So we now have Gunther van Loon, Marco de Bruin, and Catherine de la Salle, the three of them. They now have experience in looking at those cases, where to look for when you have an ultrasound. So it is possible, but we have to work that out and learn your vet to do that. But it will be only limited to hospitals, I think. It's not for the regular vet to do. But we have to get a feel for it. Because what I was already saying, I mean, that there are subclinical cases out there for a longer time. And we have to find those. Yeah. Another question.
So if we could bring our horses in to a vet that knew how to do this, and it could be identified as what it was in advance, if they knew how to read the ultrasound. Like, can I bring my horse in tomorrow?
That's what I'm saying. We are working on that.
Okay.
But it's not easy. It is possible, but it's not easy for your regular home vet, and it might be possible for your specialist in your equine hospital.
So can my vet call you?
That's no problem. He can call me, and then I will ask my three medicine colleagues if they are willing to come to your place when you pay the ticket and check your horses. I'm serious about that.
I think, well, he has the top of the line equipment as far as the sonograms go. He's a very experienced vet. So maybe it's a possibility.
But we first tried to work this out in the Netherlands. You're going too fast.
Okay.
But you have the most recent information. No, we try to work this out in the Netherlands in a large population. And if we really can make a clue, find a clue on that, of course, we should do a similar thing here in the US and ask you to come and check those horses. But maybe the genes will tell us more in what families we should look. So we keep in contact, no problem. But this is, I'm telling you, this is just right from the spot where we're at now. It's possible, but it's difficult. It's possible. We're working on that. And as I said, we are now already involved in stenting this disease, so we have some expertise, and we are very willing to share it, but we have to make one step further. Yeah. Another question.
If you find out there is some problem, is there any chance to fix it?
That's what was I explaining, is the stenting. So to close the connection between the aorta and the pulmonary artery. The stent, that's what also used in human beings, just to close a opening. That might be a clue for the subclinical case when there's a connection with the aorta and the pulmonary artery. The sudden death, we cannot prevent that. And you should already remember that you're familiar with the horse Gribaldi, the one-blood stallion which dropped dead at Chocomole. So normal horses, so a horse which is performing, that was I think semen was collected on that horse, he can drop dead too of this disease. The only thing, it is in the Friesian horse, you see it's a very specific entity. This is a very more characteristics, let's say it like that. So again, talking about genes, talking about genetic environmental interaction, this is a disease where there's also an environment involved. When the horse is challenged, then things can go wrong. And when you have a higher genetic susceptibility, then things will more easily get wrong. And well, in the Friesian horse there is a genetic susceptibility. But I come to that with proof in numbers.
Is there an age and sex predilection?
I come to that in a minute. Yeah,
Okay.
yeah.
As far as the symptoms go or the signs go, before you know there's a problem, that's what that other slide was with a rapid heartbeat and the being able to see the jugular, and that's before you even realize there's a problem. If you look for
Yeah,
those
because
things-
what you see on the jugular, you can see it and you can feel it. Because you see it pulsating like that, then you know that there's a connection between the aorta and the pulmonary artery. There's too much pressure in the jugular system, in the venous system. That's how you see it. Your vet should be able to see
you
that.
see that right away.
And we should train your vet to have a look for that. So in fact, I'm here to teach you, and you can teach your vet.
Well, that goes over real well here.
And if your vet have questions, contact us. I mean, not me. I'm not doing it alone. I'm happy to be here for you and express what me and my colleagues are finding. So this is what I'm talking about. Is you see here when we looked at the cases admitted to medicine, and we saw that 9 out of 12 horses had an aortic rupture. So 3 horses of other breeds had it. So this is the environment which is involved. So there's genes are involved in that, but the genes have to be challenged, in fact. And we have seen this disease from around 6 months to horses in older years on that. But we should be able to discover that at young age. That's our challenge, and we're working on that. So this is a quantitative proof that there's a genetic susceptibility within the Friesian horse group. Talking about phenotypes now. The third disease. Any questions about the aorta at this stage?
2 recessive genes? Is it 2 recessive genes? Do you know yet?
We don't know yet. No. I will let you know in a minute. First, yeah.
You said 6 months to older horses. What's the oldest age that they went on, that you have found?
I don't. I think around 8 years, but I don't have a specific clue yet. We're working on the phenotypic paper. We'll be there hopefully for the AEP. So you will get the numbers. No worries about that. Yep.
Is there any evidence, even though it's a genetic disease, that, say, something in the environment of the mare during gestation actually makes the genetic bias actually evident?
I was talking about the stallion Grimaldi, and he suffered from this disease too, while the semen was collected from him. That's the environmental factor. His genes, his body was challenged, and so it can happen also in non-Friesian horses. The only thing is, we see it in Friesian horses happening more in a higher frequency.
I was just wondering if someone had looked at the care of the mare during the time that the foal that eventually developed the disease was cared for. Like, was there some pattern in how the mare?
We don't know yet. I mean, until today, it was okay. We know it. I mean, in Utrecht, we were very familiar with the disease. In Belgium, there weren't. And if you talk about the rest of the world, they don't either know it. So we try to get the information on paper now and distribute it to you. So there's not much known about that. But if we have the ultrasound clue, and we can, in families, susceptible families, we can detect those families, and we can check those foals, for example, a cohort of foals, you might as well find it in the early stage. We don't know yet. More questions on the aorta, we come back to that. Go to the Megaesophagus. Again, a group of people working on that. Specialists, medicine specialists, pathology specialists, surgeons. Okay, this is everybody is probably familiar with this. And what I found very striking in this disease is that I was called by my colleagues in Friesland, and that they say, Wim, well, we should really have a look at this, because we see it in foals now that that milk is coming out of the nostrils. I must say, I was in South Africa in November giving this similar presentation to Friesian horse owners, and they indeed addressed that to me also, that they say, well, we had foals with milk coming from the nostrils, and well, that is not normal. And in fact, well, food and saliva coming from the nostrils and the mouth, the suspicion of reoccurrence. You think it's an obstruction of food. We see a too wide and weak esophagus with less motility. But the main item, in fact, what happened now is that we also discovered that in foals. And normally we saw at older age that the horse already had that for a few times, and they say, okay, it will be a Megaesophagus. The obstruction of the esophagus we also see in other breeds. Again, there's also an environmental factor. When you give them too compact feet, then they will get, the horse can get an obstruction of the esophagus. Friesian, non-Friesians. But nevertheless, in Friesian we see it happening more often, and also in a rather characteristic way. So what we saw is that the foals, they were milk was coming out the nostrils, one. Secondly, the vets in Holland, they took a scope and they saw already at foal age that the esophagus had problems. So they even detected that the foals which were diagnosed as having a pneumonia now in fact had that pneumonia because of milk coming out of the nostrils and into their lungs. So it's already there at young age, this disease. Some horses can grow over it, others will have a remaining problem with that. So how do you come up with a diagnosis? The case history, like I said to you, the symptoms. We do an endoscopy without any sedation, and we make contrast radiographs. That's in fact a golden standard to come up with a final diagnosis. And we are about to publish that. We looked at needle EMG. You know what EMG is? Electromyography. You put a needle in muscle, and then you can detect if it's a muscle disease or a neurogenic disease. And we did that with a cohort of foals and adult horses. We checked that, and we think we have found a clue on the EMG already. So also in the live horse, to come to a final diagnosis that this is wrong with the horse. So maybe even at foal age, we could detect susceptible foals and discriminate them from non-susceptible foals. So I must say, we did this in collaboration with the Stadboek. The Stadboek paid for this, and our veterinarians, mainly in Friesland, they supported us when it was a foal or a more adult horse which suffered from this, that it was sent to us, and we were able to do all the diagnostic procedures. So we are about to publish it, and we found out that needle EMG is a clue for that. So we can come up with a diagnosis. And there is a neurogenic problem probably in the esophagus, which is wrong, going wrong. This is what you see. You see here there's fluid remaining and also some food. And this is in fact the normal esophageal obstruction which you have also in horses of other breeds. Just to give a clue to you what's happening here. So in the Friesian horse there is a neurogenic disturbance in one way or another. This is the therapy. So this is under anesthesia. My colleague Marianne Sloot flush it and improve the passage of food, of course. But nevertheless, in fact, the cause we cannot treat. We don't know what's happening yet, but we think it's neurogenic disturbances. The only thing what you can do is, like in other horses with obstruction, is adjust the food. So mashed pelleted feed or fine cut roughage, or put them at pasture, and that's how you can prevent it from occurring. Pathogenesis, we're working on that. This is the esophagus. The upper part is muscles which can contract because we can stimulate that. The more lower part here is muscles which we cannot influence with our mind. And that's why it's developing. You see a big sac developing here from the esophagus to the stomach. In the thorax, there you see it developing. So there is a disturbance in the smooth muscle. The causes are known. We think it's, well, you also see it in humans. We think there's an environmental factor, maybe an autoimmune inflammation, and in a genetically predisposed population. That's what they think about human achalasia. And by our recent microscopic studies, we have found out that there's a neurogenic disturbance. But I'll come back to that in a minute. So now the epidemiology, and again you see that we had problems with the obstruction of the esophagus. We had 42 horses and 15 Friesians. So there's a susceptibility in Friesians, lower than the aortic rupture, much lower than dwarfism or hydrocephalus. But I'll come back to that in a minute. So this is a complex disease where you see that there is a genetic background, but also the environment will challenge the genes, and then it will develop more easily. This is what we found out in Garij, private clinic in Utrecht. Talking about ages, you see here, especially in private practice, that they also already saw it at young age, at 1 week of age, that the esophagus was not functioning very well, so that action had to be taken to prevent it. Any question on the Megaesophagus?
Is that polygenic?
Sorry?
Polygenic or a singular case?
Polygenetic.
Right.
Yeah, when you talk about these diseases, when there's not a, say, 100% or very high prevalence in the breed, then there are more genes probably involved. It will be more difficult to find it. Nevertheless, I mean, if there's a large environmental challenges, it still could be one gene who is involved, but apparently needs more environmental challenge to develop in the phenotype. So we hope it's monogenic because it's easy to find. Complex is difficult to find. We need more samples. Hydrocephalus, and we think there's one gene involved in that. Again, I would like to thank the people from Pretoria who sent us some samples. This is what the disease is all about. The diagnosis is pretty easy. This is on the radiographs, and this is on the CT. And what we think now is what's happening there. It's just recently came out of the lab, that there's a foramen where veins are going through, the jugular vein, for example. And what will happen in those folds is that apparently the foramen is too small. You get an obstruction of the vein and also an obstruction of the cerebrospinal fluid, the fluid in the brain. It's stuck in the brain. It cannot be transported to the blood circulation anymore. So then you get an obstruction because of a too narrow foramen. Then you get a hydrocephalus developing, and then the mare says, okay, bye-bye, get rid of the fold. So we think that the background of this entity is probably a chondrodysplasia, so a cartilage bone disturbance. That's why we're thinking that, and we think we have a clue. If that is the case, it might be easy to find it on the genome, because there's a similar disease in human beings. We are now working on that, but this is probably the phenotypic background of this disease. Yes.
Do you know when in utero that it starts to develop like that, so you could do like an ultrasound to see it?
No, it can develop on different ages. Let's say it like that. We don't know yet. No, we have seen the different ages. You can see it here at those ages here. So that young, but also at older age with hair on it. So we don't know what the signal is in that. And nevertheless, when this develops, then the foal has to leave the uterus. That's logically. So it just came out of CT studies from Ghent, and again we will publish that and send it to you. There's an MRI image of the hydrocephalus. Well, numbers we don't have yet, but we know that it's existing and that it's happening in some cases. Okay, so I showed you now the 4 diseases and make this statement. Everything has a genetic background, not until the country has been proven, so it does not only count for the negative genes, but also for the positive genes. And just to sum up, to let you know how far we have come, how can DNA help us? It's at the base of our existence, of course. It is good for science, so it's easy for me to get people work on this, and hopefully to get funding. What we can do, what is my passion to work on that, is that I'm not able to cure an animal, but maybe a breed. Mechanisms are involved in that. I mean, when you have seen the phenotype, when you find a gene, then you can understand what's going on, and maybe you can interact at a certain age, a certain stage. Then you talk about gene treatment. Well, might be a possibility. Nevertheless, the diagnostic and the therapeutic tools, we can develop that when we understand what's going on. And talking about very positive genes, in the thoroughbred they're talking about a speed gene that discovered that. They made a correlation between the genome and the phenotype, the speed. So there are possibilities also to look at this in a positive way. But we have to get rid of those 4 entities. Ozius already wrote down in his book that talking about dwarfs as the most simple disease, recessive disease, homozygotic, that when 10% of the population is heterozygotic, then 1 out of 4 foals would be a dwarf. So when you talk about 4,000 foals, well, you should have 10 dwarfs a year. I saw around 40 foals in the last 8 years, so 5 foals per year, and it's decreasing now because the stud book asks stallion owners, the mare owners, when there's a chance to develop it, when they know it, that they should prevent the owner from breeding with that combination. So I see a very big decline in happening this or something else happening to the foal. So this will be a clue, I think. So we now have the GWAS, the SNP technology, to come to a whole genome scan to find on the genome where a possible clue is. And that's what we did already for the dwarfism. And when you have find the location on the chromosome, then you have to go to a candidate gene approach. So then you have to look in the human breed, in humans. That is bred too. When you look at the Amish population here in the US, you see a similar phenomenon. So we are allowed to talk about that. The candidate gene approach, so is there a similar disease in human beings where we can learn from to transpose to our horse as well? Just have a look how far we have come now. A genetic defect is looking at a small piece of metal in a wood chip. This is the human genome, so we talk about 25,000 genes. You think it's simple, 25,000 genes, but there is also a gene interaction, there's a gene-environment interaction, there's an environment-gene interaction, so it's much more complicated than that. Nevertheless, we can try to find a genetic clue. And now I will talk about the 4 entities and just let you know how far we have come. We've published this paper, probably it's on your website, or you can obtain it via Jason. About the phenotype, we described how the dwarfs look like, and we just published in 2010 the paper on the chromosome 40. We found out by using the genome-wide association study, and it's unique what we did, also in veterinary medicine, veterinary science, and especially in equine science, that we found out that the location of the dwarf gene is in chromosome 40. So we know where it is at which chromosome, we know the location, and what we try to do now, we're working on that very hard, is to find a gene. Because if you find a gene, then it's allowed to do a test. I mean, if you don't have, well, we can come up with a test now, but it has a lower specificity because we're talking about a region. There could be a chance that you say, okay, your horse is positive, but there is a chance that it's not true if you're not looking at the gene. So we have to find a gene, to make the test with the highest specificity. And the stud book is supporting that. So before that time we won't have a test yet, as it seems. So we now are doing a second one with 40 samples, and just to check if the chromosome 40 is the only chromosome where the disease is, and then, well, hopefully it's a piece of cake to find the gene in the near future. When we talk about aortic rupture, we are now involved in the microscopic diagnosis in a group of horses, more than 20, and we found out that there's disturbance in the collagen. We saw less collagen on the location where the rupture is, and we saw a different wave pattern. So it might be that those horses have a different collagen setup. Maybe that's also connected to the higher elasticity in the tendons. We don't know yet, but we're thinking about that. Nevertheless, this is how far we have come, and we are about to do a genome-wide association 32 after we finish the dwarfism and the hydrocephalus study. So we are about to do that. Then the Megaesophagus. As I told you before, we have come to the microscopic diagnosis. There is a neurogenic disturbance in the esophagus. How it develops, we don't know yet. We can diagnose it by use of an EMG. And there's also a possibility to do a genome-wide association study, a scan, a genome scan. But probably we need more samples because it has a polygenetic background. But we are about to do that too. And last but not least, the hydrocephalus. I already told you, just straight from the lab, how we think it develops. There is a foramen which is too small, probably because of a discal dysplasia, a bone cartilage disturbance. And we are now, but the Crow is doing that from Wageningen, looking at the genome scan, and we hope to find at least a chromosome like with the dwarfs, where the gene is situated. And when we find the location, confirmed, say, the location of the dwarfism gene, and confirmed the location of the hydrocephalus gene, we are about to do a sequencing, so looking at the A, T, C, and G, the base pairs, and to find the gene in a hopefully fast and easy way. We don't know yet, but there's a possibility to do that. Just take one diseased individual, one normal individual, make a genome scan on that, so on that location where the aberration is, and then check for all the base pairs which one is disturbed. And hopefully we have then the clue where the gene is at. Okay, take-home messages. I made an inventory of only a small group of patients. We think this is the situation in the Netherlands. You saw that I already also got samples from South Africa. There's a similar problem. I think there's a similar problem here in the US too. We talk about the same breed, the same horses. We have a major genetic predisposition at least for dwarfism and also for hydrocephalus, for the aortic rupture, but I think especially for Megaesophagus it will be more complicated, there will be more genes involved. And last but not least, we need further research, of course, and further funding to come to more definitive conclusions. So, I must say, again, I would like to thank the stud book and also you for inviting me here and give me the opportunity to give this information to you. But nevertheless, all hands on deck, and we should work on this because, well, we have some challenges, like I said before. But again, I would like to give you the challenge that breeding is not a gambling game anymore. When we use modern technology, when we use it in a proper way, we can come to a more healthier breed, Friesian breed, also one breed, all breeds, and I give you the opportunity and the challenge to do that. I would like to thank you for your kind attention.
I have a question. Is it the case that for any of these diseases, if you identify a particular gene that is the responsible gene and develop a test, that test will be economically feasible, that will be a relatively inexpensive type of test, or is it, we talking a very complicated, multi-thousand-dollar type of test?
No, I mean, Henk van Heijn was here a couple of years ago, and of course we are in connection with his lab. He's also doing the blood testing for the Friesian horse breed. So we hope that when we have found the gene, that we can come to a good agreement that he can do the test at low cost. Well, we would like to, of course, by using those tests, also raise a little bit money for the next generation test. But nevertheless, it should be at a low cost. That's what we hope for. That's one. Secondly, we are also looking at different breeds. So we do this genome scan not only for the Friesian breed, but we compare the Friesian breed with other breeds to find a clue what's happening in other inbred breeds, and to see how, for example, the tissue quality is in other breeds. Is it true that with the Friesian horse breed we selected in a certain direction, and that might be the background between all those diseases? We don't yet know yet, but we hope to find and give you the information in the near future about that. Yes.
Yeah, did anyone look at if there's a relationship between the inbreeding coefficient of the mare or the sire onto the baby?
The question is inbreeding coefficient. No, we didn't make a relation on that. I mean, we know that by inbreeding you get, say, the negative genes also becoming homozygous and a chance to deliver a phenotype. That's the background. We did make a correlation. We think it's there, and we have already some proof that the Friesian horse breed, but other breeds, they have to deal with some form of inbreeding, not only in the numbers, the percentage, but also when we look at the SNP chips, at the markers, at the 50,000 markers. Mm-hmm. And what our challenge is, when we can look at in a detail like that, and we can see where it's more homozygous and where not. And maybe we can explain then why, again, those diseases are developing. Apparently, maybe in a specific location, our Friesian horses are getting too much homozygous, and we should only change that direction. I don't know yet, but the information is on its way. That's what I'm saying. More questions?
I think we're talking about recessive genes for all four animals.
Hopefully.
And you'll never resolve that issue. Take many generations to get rid of it. We have different phenotypes for each. The two obvious ones are Hydrocephalus and Dwarfism. Those are the clinical presentations, and that's pretty obvious. The ones that are most mystifying, I think, are the Megaesophagus, which I don't know if that presents itself immediately. If the esophagus is in the newborn foal is enlarged, or it enlarges with time, it becomes more problematic or not. I think if you look at the wall of the esophagus and stain it with a nerve stain, you might find there's a paucity of the plexus, the nerve plexus, that stimulates the esophageal muscle so that they can swallow, and the esophagus will not expand or dilate with time. Is that a fact or not? Is it large at birth, or is it enlarged over time?
We're not aware of studies how that develops yet, but we will have a look at it, because we proved now just recently that there is a disturbance in the number of, say, neurogenic cells in the esophagus. So now we have to go back and see how it develops from embryo to foal to adult horse. We don't know yet. It's similar like in the aortic rupture. We see that there's a transverse cut in the aorta. So apparently that is in the same spot. It seems that the embryo is connecting tissue to each other like that. So we will work on that. What we already proved is that this disease is existing on full age. That's why I was saying that milk is coming from the nostrils. We have proved by using the endoscope that the esophagus is not that contractile, that it's too weak. So it's already there at full age. And maybe even by using the EMG equipment, we can look for those folds at young age already and screen them. Well, not the Megaesophagus as such, but the pneumonia, secondary from it.
Right. So the aspiration pneumonia.
Yeah.
Early full death.
Yeah. So what we did, we saw this disease at older age, but now because we were so smart and we had access to an endoscope, we already checked the foals with had a pneumonia at young age, and milk is coming from the nostril. Now we proved that already at young age we see that disease, so it's developing gradually. And we know that some horses can be cured from it, or can grow over it, let's say like that. But we also know that foals suffer from it already because of the aspiration pneumonia, and they die from that entity.
So the phenotypic expressions are evolving or variable with those two entities.
Yeah.
They can be immediate or they can be delayed.
Yeah.
Obviously.
Again, it's a chance. I'm pointing towards you because you came up with this question. The interaction between the genes and the environment. When you have a susceptible foal, you take care of that in a very proper way. And of course, ask your vet to come by and medicate with antibiotics and clenbuterol, etc. Then you can manage it. If you don't do that, if you don't want to spend the money, then you will lose the foal. That's really how it works. You understand what I'm saying? No,
I'm not sure the value of doing that.
Okay. Yeah. More questions?
Does Megaesophagus lead to ruptured esophagus?
Good question. The question is, can this Megaesophagus rupture? And the answer is yes. We have seen recently 2 cases where we saw a longitudinal rupture of the Megaesophagus. So the horses, adult horses, 1, 2 years old, were brought into the medicine clinic with colics, a symptom of colics, and they had food in the thorax and things like that. So there was a longitudinal rupture. It was like an aneurysm. In fact, the Megaesophagus is like an aneurysm of the esophagus. And then you see a longitudinal rupture. So that's how a aneurysma in a esophagus or a vessel that's what's happening to it, a longitudinal tear. That's why it's so, I'm fascinated with the word, but we have to look in another direction when you look at the aortic rupture. Probably it has to do with 2 embryonic tissues coming together, have a locus minoris resistentiator, or a spot where there's not good tissue quality, and then the rupture develops there. It's a transverse rupture. Good question.
Could that be related to the one thing that's known about Friesians is they say they're so stoic, and when they colic and they finally show you a sign that they're colicking, usually it's too late, and we lose a lot of Friesians to colic. Could it have something to do with the Megaesophagus?
The question is, do we lose horses because of Megaesophagus when we don't know? That could be the case, yes. Yeah, but again, that's what I'm saying. I mean, if the only answer to that is doing research. I mean, if you have a sick horse, if you have a Friesian horse with dropped dead, just make sure there's a good pathological report on it. And I know that you are working on that. That's the information we need. Get a full workup, pathological report on that, and get the DNA, then we come a step further. That's the only solution. And a nice example of that is that, we had for example, the foal, and an owner would like to do the research on the foal because it dropped dead, and then it came out that it was full of parasites. So you think it's an aortic rupture foal, but it was just full of parasites. So before you say it's because of aortic rupture, just get the diagnosis there, and then you can get a step further. And if you need help, I'm very happy to give the information to you. That's why I'm standing here, and we try to publish or perish, but we have to write it down, and then you have the papers. You can have all my papers just to educate your veterinarian, and then we can come to a higher level. Thank you very much.